What happens when a standard surgical procedure physically shortens a biological ecosystem by, well, nearly a third, and in the process permanently turns off its primary irrigation system?
Right. It's a question that really forces us to completely re-examine our medical assumptions. Because in medicine, we often focus purely on the primary goal of a surgery, removing a severe pathology like cancer, fibroids, or endometriosis.
Yeah, the immediate life-saving or pain-relieving goal.
Exactly. But we don't always spend enough time mapping out the functional aftermath for the patient's day-to-day life.
And to get to the bottom of this specific ecosystem shift, we are pulling from a really fascinating stack of sources for you today. We are looking at clinical studies on vaginal length and sexual function, surgical guidelines from the UK's National Health Service, and NICE. And this is the best part. We are cross-referencing all of that clinical data with highly candid, real-world patient accounts from Reddit forums.
The contrast in those sources is just vital. Because what we find in a controlled clinical trial setting, it often completely misses the nuanced, lived reality of the patients who are actually navigating these changes in their own bodies.
So true. If you are someone going into this surgery, or maybe someone supporting a loved one, or just someone who wants to understand the incredible structural engineering of the human body, this deep dive is going to fundamentally change how you view anatomy. So let's jump in.
Let's do it.
Before we can talk about where the moisture goes, we have to understand the container itself, right? I mean, I have to assume that if you are removing an organ from the reproductive system, you are inevitably altering the structural boundaries of that space.
You absolutely are. And to understand the scale of that alteration, we need to clarify what is actually being removed. Because the medical terminology here, it often trips people up.
For sure.
The two main procedures we are comparing today are a total hysterectomy and a subtotal, which is sometimes called a supracervical hysterectomy.
Okay, let me see if I have the baseline right here. In a subtotal hysterectomy, the surgeon removes the upper part of the uterus, but they leave the cervix completely intact.
Correct.
And the cervix is essentially the lower, narrow bottleneck of the uterus that connects directly to the vaginal canal.
That is the anatomy in a nutshell. But in a total hysterectomy, both the uterus and that cervical bottleneck are entirely removed.
So basically, by removing the cervix, you are fundamentally removing the roof of the vaginal canal.
You are. The surgeon is taking away the structural apex of the vagina. And because that opening now leads straight into the pelvic cavity, the surgeon has to physically close it.
Right, they can't just leave it open.
No, definitely not. They stitch the top of the vaginal canal shut, creating what is known in the medical community as a vaginal cuff. And this is where we see the most dramatic architectural change.
I mean, it sounds dramatic.
It is. A study by Dusan and colleagues actually measured vaginal lengths before and after these two specific procedures.
Oh, wow. What do the measurements actually look like? Are we talking about like a millimeter of difference here?
The numbers are staggering, actually. For patients undergoing a subtotal hysterectomy, meaning the cervix remains in place to act as that structural roof, there was almost no change in the length of the vaginal canal.
Really?
Yeah, it went from an average of 9.9 centimeters pre-surgery to 9.8 centimeters post-surgery.
Which makes sense, I guess. The basic structural integrity of the canal itself hasn't been touched.
Exactly. But for patients undergoing a total hysterectomy, the average vaginal length dropped to 6.6 centimeters.
Wait, from 10 centimeters down to 6.6.
Right.
You are talking about losing nearly a third of the entire length of the canal.
It is a massive structural reduction. And the surgical technique dictates just how much of that length is sacrificed. A separate study by Katar looked at how surgeons actually sew that newly formed cuff closed.
Okay.
They found that if a surgeon uses a vertical cuff closure, they preserve a bit more length, averaging about 7.51 centimeters. But a horizontal closure drops it down to 6.61 centimeters.
Okay, visualize taking the tailored sleeve of a shirt, right, cutting off the cuff at the wrist, and then sewing the fabric shut.
That's a great way to picture it.
If you sew it horizontally, you are pulling the top and bottom fabric together, which naturally hikes up the entire sleeve, so you lose more length. But if you pinch it and sew it vertically, you can preserve a bit more of the sleeve's natural reach.
That is a highly accurate way to picture the mechanics of the closure. And the foreshortening, well, it can be much more severe depending on the pathology being treated.
Like what kind of pathology?
If a patient requires a radical hysterectomy combined with radiation therapy, say, for advanced cervical cancer, the surrounding tissue can shrink and scar drastically. We have a case report in the sources of a patient whose vaginal canal foreshortened to just 4.5 centimeters.
4.5 centimeters. That completely alters how that person physically interacts with the world, let alone how they experience intimacy.
The physical and psychological impact is profound, but the medical engineering used to address that extreme foreshortening is remarkable. In that specific case report, surgeons performed an autologous buccal mucosa graft.
Autologous buccal mucosa graft. Okay, break that down for us.
They harvested tissue from the inside of the patient's cheek, that's the buccal mucosa, and they used it to surgically rebuild the top of the vaginal canal, successfully extending it from 4.5 centimeters back up to 8 centimeters.
What? They rebuilt a third of the vaginal canal using the inside of someone's mouth.
They did.
I am constantly amazed by what surgeons can do. But why chick tissue? Out of all the tissues in the body, why does that work so well?
Well, if we look at the cellular biology, vaginal and oral buccal mucosa are nearly identical environments. They are both hairless, non-keratinized, stratified squamous epithelia.
Whoa, hold on. Non-keratinized stratified squamous epithelia. That sounds like a brutal question on a medical school final.
It does, doesn't it?
Are we basically just saying it's a stretchy, layered, perpetually moist tissue, unlike the tough, dry, keratinized skin on the outside of our hands?
You nailed the translation perfectly. Because it is non-keratinized, it doesn't form that hard outer layer of dead cells.
Right.
It is designed to be moist, it has a dense underlying layer of elastic fibers, and crucially, it has an incredibly robust blood supply. Because the environments are so similar, the graft takes to the new location beautifully and integrates with the surrounding blood vessels.
That is a phenomenal piece of biological recycling. But taking us back to the standard total hysterectomy, this brings up a massive logistical puzzle.
What's that?
Well, if you are structurally removing the top portion of this canal, taking away the cervix and stitching it shut, doesn't that immediately change the entire fluid ecosystem inside?
It alters it completely. To understand the scale of the disruption, we really have to map out the spatial geography of where natural vaginal moisture actually originates.
Because it's not just coming from nowhere.
Right. It is not just one uniform mechanism. It is a highly coordinated three-part system.
Okay, let's map the geography. Where is the moisture actually coming from?
First, we have the top-down system, which is driven entirely by the cervix. The cervix produces cervical mucus, which is a complex viscoelastic gel made primarily of mucin glycoproteins, water, and antimicrobial proteins.
Translating the chemistry, here we are talking about a thick, stretchy, protein-rich gel that changes its consistency, right?
Correct. Depending on the hormonal fluctuations in a woman's menstrual cycle, the mucus can be thick and plug-like or thin and watery. And this mucus flows downward, continuously coating the walls of the vaginal canal from the top down.
Like a slow drip irrigation system positioned at the very top of a garden.
Exactly. The second part of the system is the walls themselves. Interestingly, the vaginal walls do not have any glands of their own.
Really? No glands at all?
None. They produce moisture through a physiological process called transudation.
Transudation. Walk us through how a wall without glands produces liquid.
Think of dew forming on a lawn in the early morning.
Okay.
The vaginal walls are surrounded by a dense, intricate network of blood vessels. When blood flow increases to the pelvic area, a process heavily regulated by the hormone estrogen and autonomic nerve signals, the pressure actually forces fluid from the blood plasma to seep directly through the vaginal skin.
Wow.
Yeah, this transudate dew mixes with shedded cells and the cervical mucus to create the baseline vaginal environment.
So we have the top-down cervical drip, and we have the walls literally sweating out this transudate dew.
Yeah.
What is the final piece of the geography?
The entrance. Located just inside the opening of the vagina are the Bartholin's glands and the Skene's glands. These glands are entirely responsible for the immediate high-volume lubrication that occurs during sexual arousal.
Wait a second. If a total hysterectomy removes the cervix, you lose that entire top-down irrigation system. Logically, textbooks might imply a patient is left completely dry. But based on this geography, the Bartholin's glands at the entrance aren't touched by the surgery at all.
This is exactly where the clinical assumptions and the real-world experiences from the hysterectomy subreddit collide in a really fascinating way.
Tell me more about that.
Well, doctors often warn of severe dryness, but the patient voices tell a much more localized story.
The Reddit sources were so illuminating for this. People are wonderfully candid when they can speak anonymously about their bodies. And if you are listening and wondering if you are the only one experiencing strange shifts in your biology, These forms prove you are absolutely not alone.
Right, and what these patients consistently report is immense relief that they do not necessarily lose their arousal lubrication.
Because the entrance glands are still there.
Exactly. One user explicitly wrote, "I'm producing more lubrication, not less. The cervix only provides cervical mucus anyway." Another shared that even 3 years post-op, they haven't needed to use external lube for intimacy.
So they get the arousal signal and they do their job.
Yes. But what profoundly changes, according to the patient consensus, is the daily baseline moisture, the everyday random wetness.
Oh, because that top-down drip is gone.
Precisely. Without the cervix, the cyclical fluctuations of thick and thin mucus just disappear. One patient described a complete shift in their daily discharge, noting that it sometimes comes out in thicker clumps rather than a continuous smooth coating because that top-down dilution is gone.
That makes structural sense, but wait, I have a logical hang-up here.
What is it?
If the walls are sweating out their own moisture that transudate do, why would losing the cervix make the middle of the canal dry? The walls are still there, the blood vessels are still there. Shouldn't they just keep sweating?
You are pulling on a very important thread there, one that highlights the hidden casualties of major surgery, which are the nerve pathways.
Nerves.
Yeah. The anatomical area surrounding the cervix and the upper vagina is heavily innervated by a complex network called the Frankenhauser plexus alongside various pelvic and hypogastric nerves.
It's essentially a major neurological junction box for the entire pelvic region.
It is. When a surgeon performs a total hysterectomy, they have to navigate an incredibly congested anatomical neighborhood. They must meticulously cut away the cervix while separating the bladder in the front and the bowels in the back.
That sounds intense.
It's very delicate. And during that separation, those autonomic nerve fibers can be easily disrupted, stretched, or even permanently severed.
Even if the surgeon has, like, flawless technique.
Even with flawless technique. The physical trauma to the area is just significant. And remember how we said the transudate moisture on the walls relies on blood flow?
Right.
If the nerves that signal those specific blood vessels to dilate are damaged, you get a significant decrease in what is clinically called vaginal pulse amplitude.
Meaning less blood flow.
Exactly. Less blood flow means less hydrostatic pressure, which means less transudate dew pushed through the walls.
So synthesizing this, the moisture doesn't just disappear, its spatial distribution completely shifts. You go from a whole canal coating driven by the top-down mucus and the wall transudate to an incredibly entrance-heavy distribution.
That's a perfect summary.
You are relying almost entirely on those Bartholin's glands at the front door. It's like turning off the irrigation system for a whole garden, but keeping a garden hose running full blast right at the front gate. The front gets watered, but the back corner is going to turn into a desert.
A desert is a harsh but unfortunately accurate analogy for what many patients experience. And that back corner, the newly created vaginal cuff, is where patients experience the most profound, often debilitating impact on their intimacy.
Let's talk about the reality of that impact. The sources included data on the Female Sexual Function Index, the FSFI. For context, this is a standardized clinical questionnaire that measures a patient's desire, arousal, lubrication, orgasm satisfaction, and pain levels.
The comparative data here is just striking. The Dozen study found that while both total and subtotal hysterectomies caused some temporary decline in sexual function due to general surgical recovery, the long-term drop was massively different.
How different?
Well, patients who had a subtotal hysterectomy, meaning they kept the cervix and that top-down moisture, saw only a minimal 1.4-point drop in their overall FSFI scores.
And the patients who had the total hysterectomy?
They experienced a 9.2-point drop. That represents a highly significant, clinically measurable decline in their quality of sexual life.
Wow. So if we lose a third of the canal's length, shift all the moisture to the front door, and replace the flexible cervical tissue with a stitched, scarred cuff, that 9-point drop isn't just an abstract statistic. It translates to real physical pain for the patient.
Specifically, it translates to dyspareunia, which is the medical term for painful intercourse. But patients post-total hysterectomy frequently report a very specific type of dyspareunia, deep pain.
Deep pain as opposed to entry pain.
Yes, entry pain is typically associated with conditions like vaginismus or a lack of that Bartholin's gland arousal lubrication. But deep pain after this surgery comes from the sensation of literally hitting a structural wall.
Because the canal is shorter.
Exactly. The vaginal cuff is sitting right there at the shortened apex. It is often thickened with inflexible scar tissue. It lacks its own elasticity, and because that top-down moisture is gone, there's a tremendous amount of physical friction
Mm.
on very delicate healing tissue.
The structural realities are intimidating enough on their own, but the clinical sources point out that this ecosystem crash gets exponentially worse if the patient also had their ovaries removed during the surgery.
Right. Removing the ovaries triggers surgical menopause overnight. The sudden, drastic drop in systemic estrogen removes the primary hormonal scaffolding that supports all vaginal tissue.
And without estrogen, the tissue actually degrades on a cellular level, doesn't it?
It undergoes severe atrophy. The outer mucosal layer thins out dramatically, meaning it sheds fewer of the cells necessary for maintaining a healthy environment.
Mm.
But the deeper damage happens in the connective tissue.
What happens there?
The collagen fibers actually undergo a process called hyalinization.
Let's translate hyalinization. What is actually happening to the collagen there?
The individual collagen fibers, which are normally distinct and pliable, chemically fuse together into a glassy, rigid mass. Simultaneously, the elastin fibers in the tissue fragment and break down.
So instead of the vaginal canal acting like a flexible, moist rubber band, it becomes structurally closer to stiff, dry leather.
That's a grim way to put it, but mechanically, yes.
Combine that rigid tissue with a foreshortened canal, a scarred cuff at the top, and a lack of upper canal moisture. I mean, it is completely understandable why an FSFI score drops by 9 points.
The structural math simply doesn't work in favor of painless intimacy under those conditions. But this is where the conversation needs to pivot, because the medical field has developed highly targeted solutions for this exact structural crisis.
That's the good news. If you are listening to this and recognizing your own symptoms, this is the most important part of the deep dive. Patients do not have to just accept pain as their new normal. What are the specific interventions?
The first line of defense, particularly for patients navigating surgical menopause, is localized vaginal estrogen. This is prescribed as a cream, a small pessary tablet, or a flexible ring inserted directly into the vaginal canal.
So it's not a pill you swallow.
No, because the application is highly localized, the estrogen absorbs straight into the local tissues with very minimal systemic absorption into the rest of the bloodstream. It aggressively restores the local blood flow, signals the body to rebuild that collagen elasticity, and essentially forces the transudate moisture process to turn back on.
But localized estrogen isn't an option for everyone, right? Like if someone had an estrogen receptor positive cancer, bringing any hormones back to the environment, even locally, can be contraindicated. What is the alternative?
For those patients, non-hormonal vaginal moisturizers are the gold standard. And to be clear, we are not talking about standard sexual lubricants, which just temporarily reduce friction on the surface.
Yeah, lube is just a Band-Aid.
Exactly. We are talking about highly engineered moisturizers containing active ingredients like hyaluronic acid or polycarbophyl.
Hyaluronic acid. That is the exact same molecule people use in high-end facial skincare serums, right?
The very same molecule, used for the exact same mechanical purpose. Hyaluronic acid is a bioadhesive polymer. Its unique chemical structure allows it to bind massive amounts of water, up to 1,000 times its own weight.
That's incredible.
So when a patient applies this to the vaginal walls regularly, say 2 to 3 times a week, the polymer literally clings to the epithelial cells. It acts as a microscopic water reservoir, slowly releasing moisture over days. It mimics the natural transudate dew and physically changes the cellular hydration of the tissue over time.
It's acting as a biological sponge to replace the lost irrigation system. But what about the foreshortening? If the canal is physically shortened and the cuff is rigid with hyalinized collagen, can that be reversed?
That requires dedicated mechanical rehabilitation. Patients often work with pelvic floor physical therapists using vaginal dilators or trainers.
Okay, so physical therapy for the pelvic floor.
Yes. By combining these medical-grade dilators with hyaluronic moisturizers, patients can progressively and gently stretch the tissue over weeks and months. It relies on tissue plasticity, gently coaxing that stiff, hyalinized collagen back into a flexible, accommodating state.
It takes deliberate work, but the architecture can absolutely be adapted and rehabilitated.
It can. Though, looking at the overarching conclusions from our clinical sources, there is a growing vital realization within the surgical community.
Which is?
The loss of the cervix isn't merely the loss of a fluid source or a structural roof. We have to acknowledge it is the loss of a major erogenous zone.
Oh, because of that Frankenhauser nerve plexus we mapped out earlier.
Precisely. For many women, deep cervical stimulation is a primary neurological pathway for arousal and orgasm. Physically removing it severs those specific autonomic nerve pathways forever.
That is a massive deal.
It is. It is why preserving the cervix when it is medically safe to do so, meaning the patient has no risk of cervical cancer or severe localized disease, is shifting from an afterthought to a primary consideration for preserving long-term sexual function.
So, synthesizing everything we've unpacked in this deep dive. Yes, a total hysterectomy profoundly alters the spatial distribution of a woman's natural lubrication. By physically shortening the canal, removing the cervical irrigation system, and potentially damaging the surrounding pelvic nerves, the fundamental fluid dynamics shift.
They absolutely do.
The moisture moves from a continuous full canal coating to a heavily entrance-based system. And that spatial shift, combined with scar tissue, can cause significant measurable friction and pain at the newly created apex.
You are taking a complex, self-sustaining ecosystem and forcing it into a completely new biological paradigm.
But understanding the mechanics of that paradigm shift is incredibly empowering. Whether you are trying to understand your own post-operative anatomy or you want to know what a partner is experiencing, understanding the why allows you to ask your doctor specific, targeted questions.
Absolutely.
It allows you to confidently advocate for hyaluronic acid or localized estrogen, rather than just suffering in silence and thinking your body is broken.
Knowledge is the most effective tool we have for medical self-advocacy. You can't fix a system until you understand how the plumbing is supposed to work.
Beautifully said. Now, before we sign off, you always find a way to complicate the picture even further. What is the final thread from our sources that we didn't get to pull on?
Well, we spent this deep dive talking about moisture and structural length. But the healthy vaginal ecosystem also relies on a delicate microscopic balance.
Okay, lay it on us.
Naturally occurring vaginal amylase, an enzyme, breaks down the sugars from shedded mucosal cells. Those broken down sugars feed the healthy lactobacilli bacteria, which in turn produce lactic acid to keep the environment acidic and prevent infections.
The natural bacterial defense system.
So consider this. If a total hysterectomy removes the cervix, completely altering the top-down mucus, changing the way mucosal cells shed, and shifting the moisture dynamics so drastically, how does this newly engineered, drier architecture permanently alter the woman's vaginal microbiome?
Oh, wow.
Right. If the lactobacilli lose their primary food source, the upper canal, what microscopic opportunistic pathogens move in to take their place?
We focused entirely on the macroarchitecture, but there is an entire microscopic city relying on that ecosystem. That is a whole other level of biological engineering to think about. Thank you for taking this deep dive with us today. Remember, just like removing a load-bearing wall changes the structural stress of an entire house, altering the body changes how the entire ecosystem flows, keep asking questions, keep advocating for your own health, and we will see you on the next deep dive.